And just so that we have it on the recording and the transcript, if you guys could put your names and your numbers in the chat again. That way it's all recorded.
Tom, it's Mark.
Hey, Mark.
Do me a favor. I've got the in-person rosters here. Do me a favor, text me the approval numbers for hour 1 and hour 2.
Yep, I'll take care of it.
I can at least put those on it before they go back over to Main Street.
Roger that. Thank you.
Thank you.
If you're joining us for the second one, but you weren't part of the first one, could you please indicate that in the chat so I don't screw the roster up?
Yeah, and we'll make sure that we get 2 hours, 1 hour for each one.
Yeah, that's what we put in for. That's what the roster is going to indicate.
Take another picture.
You got the paper also. Now, if they're zooming in, how do they sign?
They do it through Tom.
Oh, okay.
So they leave their name and their number in the chat because it's recorded.
Great.
So
Okay.
they already should have taken
Yeah, good. So they'll be all signed up.
Can you guys see okay? Not very, yes.
Yeah. Can everybody see the camera or the slides there?
We can see the screen. Can't really read it, but we can see it.
Oh, okay.
I
Yeah.
don't think I can stress.
Yeah. Extension cord, good. Yeah. We're gonna check on an extension cord real quick.
Tyler, can you put it so that it's looking at the computer screen instead of the projector screen?
Yeah, back here. Because I think you'd have the same problem in this plug here.
Yeah.
Yeah.
They
Yeah, those tables should be.
have the ability. But not the function.
Yeah, right. And working on an extension cord for you guys. I'll be ready in a second. hopefully. He's doing a good job. He's enthusiastic about it. You know, I was, we had, we break out the towels, so it's, Jaws with the smoke cones. Thank you for your patience, everybody. We're working on an extension cord for the phone so that camera gets closer to the screen. So I wanted to get that truck. I think it might be relocate things. I was pretty happy with as dysfunctional as the whole place is right now because of the lack of power. So So yeah, he's like, I told Chief Florida when he was planning on coming down last week. He mentioned 2 more lines for me. I'm sure he'd love to do it. Yeah, would be able to say, yeah, just price the $750,000 truck. He's sure being a kid just right outside his house, take pictures of us.
So how you been?
I work a ton. We were just talking about, I do a lot of maintenance down here and stuff. I haven't been able to enjoy, our love of the Civil War and stuff. And you were talking about, you got stumped by what one of the medications was morphine and
Yep.
and shoot, I don't remember either.
Yeah.
But yeah, I do love that study of that.
Me too. I love to go to Gettysburg when I can.
Well, I told you I went down for the 30th anniversary.
Yeah.
I'll let you know as soon as that 35th one pops up.
Yeah.
Because that was just fantastic.
I-
Just doing behind the scenes tours of that. If you remember, you saw the movie.
Yeah.
If you remember the little, I don't know how much I talked to you about it before, but the little round top scene is actually about 2 miles outside of town.
Yeah. It's only in a whole different spot.
Yeah. But to walk up that hill,
Yeah.
the fake.
Yeah. Isn't that weird?
Yeah.
Right.
And then they go to the.
Yeah. Yeah.
I did that for the first time. I've been going since back in my woods days. Gettysburg, over 20 years.
Yeah.
I got quite a lot of days down there. And that last year was my first, last year, the year before.
It's a really weird feeling because it felt like John Buford.
Yeah, and actually, it's there's a thing online that says, because it has a lot of 30th anniversary stuff.
Yeah.
If you YouTube that, and they're up in that cupola, and it said, you're not in the actual cupola because that got burned.
Oh.
That's actually rebuilt in the late 1800s or early 1900s.
Wow.
So, but you're not the one that the real John Buford stood in, but you are the one in the movie John. Sam Elliott. You are in that one.
That's really cool.
Yeah, I do love it down there. And
No extension cord?
I don't know. It haunts to, the interest in the paranormal that I have just goes hand in hand.
Yeah.
And I took television, Nick McCall's, he since left us and was on Marlboro Fire now. But I took him down, and he had just a week prior to when we were down for 30, he read, he watched the movie, and he just fell in love with it as much as I was, and this was his first time. It's this thick.
No
It's
good.
gotta be what it's gonna be. Sorry.
Okay, I'm gonna let you put
Yeah.
this.
That's just awesome. So, yeah, we just can't get that any closer, can we?
No, not really.
Yeah. Okay. Yeah, I'm sorry, you guys, we can't find an extension cord, so we'll do the best we can. Just listen along and. So, I don't know. That would be- Is that working any better? Is that any better, you guys?
It's more at an angle now. We can't see directly at the screen.
Oh, yeah. Yeah. Will it fit on this table? We could prop it up with that box maybe?
about now?
Can read the words now.
Yep, better.
Much better.
Okay. Great, great. We're in business now. Kind of a concoction of all kinds of things going on there, but. All right, we'll have to step around the other way. So just a few cases to run by you, if you guys don't mind. Is it, you can still see it okay? So case one is a 5-year-old, and she on the mother's lap on her porch when you guys get there. She's awake. She has a tear-stained face. Color's normal, but her t-shirt's grass stained. So obviously this is, good weather, summer maybe. She's got a GCS of 15, an open clear airway. Her respiratory rate is variable, anything from 12 to 22 breaths per minute. She doesn't appear to be in any distress, and you don't notice any adventitious sounds in the lungs. Circulation looks good. She's pink, warm, and dry. Her heart rate's 120. 5-year-old, so that's probably not super duper bad. Blood pressure is 82/56. Her only complaint is that her tummy hurts. So right initially, this doesn't look like much of a 911 call, does it? And by the way, this is an actual case, you guys. So here's your focus history. She's playing around the car in the driveway when she suddenly cries out. Her mother hears her cry, sees her daughter get up and run towards her, and sees that the car had moved down a slight incline to the end of the driveway. And yeah, that's what really creeps you out. So no one saw exactly what happened. Past medical history and all that's negative, so you don't find anything. So these are your vital signs, very similar to what we started with. Mom says she's 50 pounds. When you look at her skin, she's got an 8-centimeter wide abrasion that begins on the right chest wall at the nipple line and actually extends across the chest to the left at about the level of the waist. So it kind of goes diagonally across this way, almost like a seat belt. She moves all extremities on demand. We know she's a GCS of 15. She's 99 on ambient air. I hope your brains are beginning to move. Yeah. Figure out where we need to go here. What's the significance of the injury? What do you think it suggests? Pardon? Oh, yeah. Yeah. This child has been rolled over by the car, right? So for some reason, the car may be dislodged and she was playing around it too close, got caught underneath the car. This actually happened to a real good friend of mine. His daughter was 18 months old, just running around, and he didn't know she was behind him, and he backed up the pickup truck and ran over her head. Yeah. She lives today. She's married. She's got some permanent damage on the left side of her face. She walks and talks a little slow mentally, but yeah, amazing. Yeah, she's pretty amazing. She survived that injury. So what injuries are you going to suspect? Yeah, lots of internal ones. Chest for sure, lung, heart, major vessels, maybe head and neck. Don't rule that out. Abdominal for sure. Spine, pretty much the only thing you wouldn't suspect is maybe toes. But, legs maybe are okay because she ran up to her mom. So is shock here? Is shock present? Yeah, that's right. So what my point is I want you to start thinking ahead. Can this patient go into shock? Absolutely, hands down. Your job as a first responder, a paramedic, an EMT is to prevent trouble, as best you can. You don't want the patient to deteriorate. And that's my job too. By definition, one thing to learn from this case is hypotension in children is defined as a systolic pressure that's less than 70 plus age times 2. So she's 8 years old, so that's 16 added to 70, so 86. Anything less than 86 would be considered hypotension in this case. So early signs of shock in kids is a whole lot different than it is in the adult. The adult early signs is sweating, tachycardia, hypotension. In children, they compensate a lot better than we do. So children can be in shock and actually look good. Initially, this girl looks pretty good, right? She ran from the scene of the accident. She ran up to her mother on the porch, sitting on her mother's lap. She's comfortable. Crying obviously has maybe settled down a little bit, but children don't have the benefit of increased contractility in cardiac muscle. Therefore, they don't respond with tachycardia right away. Her heart rate was okay, it was around 120, which is kind of normal in this age group. If you see a child with sustained tachycardia, that's when you raise the red flag. You start to worry. This is not right. You know, an 8-year-old with a heart rate of maybe 142 is not a good thing. So one thing I want to drive home is to make sure that you guys have a good idea of vital signs, normal vital signs in children. You have them spaced out. If you can't remember, you can do what I do and have a little card. The Brazelau tape is a real good reference for that. They'll pink and they'll give you the normal vital signs for that weight, red, purple, and so forth. So you can say, well, I've got this purple kid or a pink kid or something. I'll probably know what you're talking about. What are other signs in a child with shock? Change in mental status. This child is not showing a change in mental status, right? But what happens if suddenly she starts getting confused or doesn't recognize her mother or doesn't know where she is, or starts getting very fearful? Sometimes children, when they're changing their mental status, they get really anxious. They're very afraid. Or another red flag is when the child is not as active. When they start, kids, they're busy, they're active, they like to be, doing things and interacting. When you go and you see the kid go from recognizing mom and running to the porch to kind of floppy, then you've got a problem on your hands. Delayed capillary refill. This is a big one, and it's a later finding. So if you're starting to pick up pallor and delayed capillary refill, you got something to worry about. Do not ignore skin color that's pallor if the heart rate doesn't correlate with what you would expect. Just because the child isn't tachycardic, if they are pale, I'll throw in diaphoresis there too. If you see those signs, you've got yourself shocked until proven otherwise. Beware the quiet child, because if any of you have had experience with children, they're anything but quiet. Okay, so if a child has been traumatized by a physical event or a medical problem, and then we've got something to worry about. So why would you immobilize this child? Run over by the car. Yeah. Do you know exactly what's going on with that spine? In a car, that's thousands of pounds, right? So she said, very sudden forced compression of the chest, and then a high velocity opening up when she took her first breath after the car rolled over. So anything and everything. It could be multiple rib fractures, vertebral fractures, hard to say. So immobilization is probably key here. I wouldn't hesitate to kind of focus on the abdomen and pelvis as well because of the wounds and the way things are. She could be bleeding in the abdomen. Okay. Would you establish I or IV and give this child fluid? Yeah, definitely. Don't hesitate to spike a bag and start IV access IO, because once this child starts to deteriorate, which is going to happen, you want to be ready. Okay. Now, some would even give her fluid, the 30 milliliters per kilogram for shock anyway. You could, technically, she's not in shock yet at this moment in time. If you wanted to do the 20 cc's per kilo for children, no one would fault you on that way. Now, here's the big bugaboo. Look at here. On the way to the emergency department, let's say you're 20 minutes out, she becomes very quiet and sleepy. Does that mean her pain's under control? She's feeling better? Just the opposite. That's something to worry about. If you guys see this, you can bet she's in shock. You did the right thing and you repeated her vital signs. Heart rate's now tachycardic by definition. I should have made the number higher, but this is real world. Respiratory rate's gone up, and look at her blood pressure. It's dropping. So she's showing a change, although it's subtle. Beware the subtle changes in vital signs. It's fooled me, it's fooled you, and I'm sure if we're very careful each and every time, if we assume the worst and work backwards, we won't miss it. So this suggests shock and you better act on it. Here's her findings. This is the real thing. Look at that chest. Do you like what you see on the right side? Yeah, careful. Oh, did I move the camera? You guys can still see the board, right? Okay. So this right here, that's sub-Q emphysema underneath the skin that you see, and all that fuzz over the lung field on the right, that's pulmonary contusion. That's microbleeding all over the parenchyma of the lung. So the lung, if you opened up the chest, it would just be all this bloodied mess. It would look like even you've tenderized meat and you hit it with a hammer. That's what this is. So the weight of the car has crushed her chest. In this x-ray, it's hard to see any rib fractures, but she did have some multiple rib fractures there too. She was given 1 unit of packed red cells. That's what PRBC stands for. ICU stay. By the 3rd day, pleural effusion was found. So that means that as she heals, she was collecting fluid in the pleural space, had to have a chest tube placed. She was in the hospital for a while, but recovered in 6 weeks. Pretty significant injury. No other abdominal findings, interesting enough, except that she lacerated her liver. Why the liver? The liver, you guys, is next door to the lung. So any chest injury, always suspect the liver, and that's on the right side. So remember that the liver sits up underneath the rib cage, and a lot of people, so if patients have right-sided chest trauma, please suspect abdominal trauma as well, and make sure you do a good abdominal exam and report it in your run sheet. Abdomen distended, firm, tender right upper quadrant, bluish in color, Cullen sign, or what's the other one? Along the flanks. My mind's blanking, but you can report cyanosis in the flanks. That's a sign of bleeding internally. Okay? So
Dr.
an
Wilson?
8-year-old goes into shock. Yes.
A Brian Vane had raised his hand in the chat. I don't know if he had a question or not. I told him to put it in the chat, but he hasn't typed yet. Brian, do you have a question?
Yeah, go ahead, Brian.
No, sorry. I was just saying that I could see the X-ray image.
Okay.
Okay.
Yeah.
My apologies. Thank you.
Oh, thank you, though.
Brian, because you saw it so well, you can interpret my x-rays from now on.
Yeah, that's a poor decision.
Very good. So here's case 2, you guys. This is a 2-year-old, and this actually happened too. These are real deal cases. This is a 2-year-old that came in unresponsive, or that's your call. Don't you love it? It's like unresponsive. That's when you get the tachycardia and the shock. On arrival, a woman in her 60s, so this is grandmother, runs out of the house carrying a flaccid, unresponsive 2-year-old. He's pale and cyanotic with a gray face. Now this, you guys, is a stock photo, and it was the nearest I could find to what the child actually looked like, because I don't like, with HIPAA and everything, I don't like the real deal pictures. But so this is a stock photo of kind of what the child looked like. This is not the real patient. So this is what he looked like. So an easy question to answer: are you worried? Yeah. This is an ALS call, hands down. This is what the child looked like, unresponsive to voice or pain. So this is not good. The airway is open and clear. That's encouraging. So are they breathing? They're not ventilating really well. Look at that respiratory rate. That's agonal breaths in a child, 3 to 4 minutes, shallow, and lungs are clear. Yeah. Are you guys starting to think airway here? And assisted ventilation? I certainly hope so. Yeah. Circulation is awful. The skin is cool. The patient is dry, not diaphoretic. Kind of a hint there. Pale with cyanotic gray color to the face. The pulse isn't detectable. That's worrisome too. That's a shocky patient. You guys know that in shock, the core is selfish and wants all the blood because that's where your vital organs are. So you'll get shunting. So the peripheral pulses will be almost negligible. This blood pressure may be 30 systolic, but it's really, really difficult. Even the Dynamap and the automatic machine will have trouble picking this up. So your patient is in shock. Everybody agrees? Yeah, we still don't know why. So let's do a little digging. We talked to the grandmother. I put him down for a nap at 2 o'clock. In a half an hour, she checked him and found him on the floor. 2-year-olds go. They don't fall asleep right away. Unresponsive with open bottle of heart pills. Uh-oh. Beside him. Are you guys thinking talks now? I am, yeah. She then called 911. That was good. The prescription is for verapamil. For those of you that don't know, verapamil is a calcium channel blocker. We'll talk a little bit about how they work physiologically in a minute. 120 milligram, and by the way, they were immediate release, not extended release, and that's important to know. Extended release medications do just that, they extend their half-life. So if a patient accidentally or intentionally overdoses on extended release, they have to be in the hospital longer. There are 10 to 12 pills on the floor. The bottle was 60 on the prescription label, and guess when the fill date was? Yesterday. So we started with 60, maybe 10 or 12 on the floor, so that leaves 50 to 48 pills that could have been ingested. Frightening, right? So the remainder of the history is negative. Grandma says shots are up to date, hasn't been sick, hasn't been out, he hasn't fallen, blah, 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 you know. And of course, you're doing history as fast as you can. Okay. Hold down, go boom, you're all right? Yeah. Okay. So here's your focus exam, you guys. We already know he's got bradyapnea, which is the fancy way of saying not breathing very fast at all. He's hypotensive. So the child is in shock. There's no muscle tone. Do flaccid children worry you? Absolutely. Normal children are often more flexed in their extremities. Even a 2-year-old has a little bit more flexion. If they're no tone there and their extremities are all lying out, you got something to worry about. Check those pupils. I don't like it. They're dilating, slow to react, which means the brain's involved here. Grandmother says the child weighs about 25 pounds. So roughly what, 10, 12 kilos? Just wildly guessing. I'm not good at math, at this hour of the night. Blood glucose. Why would the patient be hyperglycemic? Anybody know? Verapamil overdose can cause hyperglycemia. That's how calcium channel blocker work. I'll tell you a little bit of physiology in a minute because of how it works. Pretty cool when you know why drugs work, how they work, and what happens when they go bad. The pulse ox reads 0 or error. Why do you think that is? There's acrocyanosis. They're not perfusing. If there's no perfusing, there's no pulse ox. There's nothing to read. Now, are you guys worried about the rhythm strip? Oh, Melissa, are you listening? See if, is Melissa on, Brian?
Yes, I'm here.
Do you think Danny Boy's going to ask you to interpret that strip?
No, because that's your job. I don't have to do that.
Oh, you're too good. Yeah. Ladies and germs, Melissa just told me in so many terms that that's a complete heart block. So you see that there's good P to P intervals, right? So if you take your calipers, your P to P is good, and R to R is so slow, my calipers won't spread out that long. So R to R is okay, P to P is good, but they don't. They're totally divorced. You see that? There's just no sense. But that QRS complex over there got a P wave in front of it, but that's just by sheer luck. There's no conduction through from the SA node to the AV node. So is this a serious problem? You bet your boot. Does the patient need paste? More than likely, especially since they're in so much trouble. So I've already touched on some of the answers here. The significance of the patient's history is an accidental overdose of a calcium channel blocker, a very serious overdose, especially in a young child. The accurate ways to assess perfusion in the child are these: the degree of activity and the mental status. Children are active, they're bright, they're alert, they're busy, they may even talk too much. When a child is lethargic, lumpy dumpy, and not talking, start to worry. Their skin color should be warm, pink, and dry. This child is gray, cyanotic, and cool. Central cyanosis indicates hypoxemia, and this patient was obviously hypoxic. Obviously, you need to administer oxygen. Are you going to establish an oral airway? More than likely. I would even maybe go as far as consider, RSI if we have available, or even sedating the child and starting an artificial airway. Pulse rate makes you worry because if a child, and this is PALS and BLS, if a child goes below the heart rate of, when do you start CPR?
Well, in an infant, it's below 60.
That's
But
correct.
how old was this child?
This child's 2. So
So
this would not have to start CPR on, but it's really important to start thinking maybe they need pace because their heart rate's so slow, or maybe a little atropine. That's more for the big boys to do in the ER. Your job is airway, breathing, circulation. Let's go look at verapamil really close on what it does. The calcium channels in a cardiac cell, especially, do allow the influx of calcium into the cell to cause the cell to contract. For those of you that took pathophys from me in paramedic school at Mount Wachusett, remember we talked about this when we were doing the sodium potassium pump, when we were talking about electrolytes. Calcium is largely an extracellular ion, as is potassium. Or intracellular, I'm sorry, I misspoke. Calcium and potassium, largely intracellular, and there's an exchange pump between sodium and potassium, same way with calcium. And when calcium gets in there, it causes the cell to do what it needs to do. So if this is blocked, if that channel is blocked, guess what? Calcium builds up and causes the cell to go into kind of a paralysis, if you will. There's no conduction. These heart cells cannot conduct electricity, and as a result, heart block. Also, what do calcium channel blockers do? But they decrease the amount of insulin secretion from the beta cells of the pancreas. Bingo. We give calcium channel blockers sometimes to insulin overdoses just for that reason. So, verapamil causes insulin secretion to drop, and what happens to the glucose then? If there's not enough insulin, glucose goes up. Sure enough, patients become hyperglycemic. So the decrease in the mentation has to do with calcium channel blockade. No neurotransmitters. Nerve can't do what they do to keep you alert and oriented. Guess what? They become lethargic. The heart I already explained. We go into AV block. Decreased contractility decreases peripheral vascular resistance. Patients go into shock, etc., etc. See how one drug can just ruin your whole body. What pulmonary complication do you think is going to happen? Obviously, they're not breathing very well. Yeah, arrest. And if the pump's not pumping, guess what happens to the venous pressure in the lungs? Venous pressure will drop. And if the venous pressure drops, the veins will leak tissue fluid. Those patients can go into pulmonary edema, right? So heart failure can result because of heart block. So do we do CPR? What do you think? It's kind of on the fence. You certainly would not be faulted for doing that, but you still have a pulse and a weak pulse. So in the strictest definition, you still have a pulse, but you have bradycardia. So go down the algorithm. What do you do for bradycardia in children?
Well, in this case, we know the H's and T's, and the T here is toxicological. Verapamil, wouldn't we just give calcium chloride?
Exactly. A1, you start a line, IV or IO, Tom, and you give them calcium chloride. That's right. Now, the exact dose of calcium chloride in this weight, I'd have to use the Brosselau tape or look it up.
20 milligrams per kilo.
Pardon?
20 milligrams per kilo.
Oh, thank you. Yeah.
For a 15 kilogram kid at 2 years old, according to my reference, it's 300 milligrams.
Yeah, good. On my phone, I have it's an app called Palm ED. I don't know if any of you are familiar with that. It's a Red Cross and it's a free app, but all your quick facts are on there. Vasopressors and antidotes for toxidromes and all that stuff.
That's the one I actually used to look it up.
What is it?
That's the one I actually used to look it up.
Yeah, well, it's a great app, Tom. Great. I
It
use
is.
it all because you and I both know that it's impossible to remember all the things. I would rather us take a moment to look it up and be accurate than guess. So insulin is blocked hyperglycemia. We know shock is present. Already explained that. Besides pulmonary edema from CHF, aspiration pneumonia is at risk because the patient's lethargic. Any obtunded lethargic patient is an aspiration risk. So it's all important for us to protect the airway. Would you guys use an oral airway in this case? Would you feel comfortable doing an OPA?
Probably.
Yeah, I would. Yeah,
No.
right. Because you overstimulate, you could cause gagging, coughing. Yeah, yeah, right. That's exactly right. Good thinking. Good thinking. I like you guys to think critical or critical thinking outside the box, not just to go down an algorithm, but to really think. Tom hit the nail on the head. You go after the cause of the bradycardia. You could give atropine, but that would be a B drug, not an A drug. Your A drug would be a calcium chloride. So this is what we started in this particular case. The patient was supported with BVM. CPR was started en route. The medics. This was a case up in Vermont that took care of. Heart rate was less than 60, and in they came. So we did the usual saline. They did this en route. You bet your boot we did the calcium chloride once they came in to the department. My partner and I, there were two docs on at the time. We did give some epinephrine as well. This is just to stimulate the vasodilatation and the shock state to get the child out of shock and to increase the heart rate. Calcium chloride is exactly right. This is the range, but Tom gave us the exact amount based on the patient's weight. Now, can you use calcium gluconate? The answer is yes, because it's the calcium that we're using. The chloride or the gluconate is only the carrier of the calcium in solution, so it doesn't really matter. Calcium chloride in a wide awake alert, I just need calcium, hurts. It actually causes a lot of irritation to the vein, and we use calcium gluconate in the ER for that purpose. In code situations, we use calcium chloride. Why glucagon, you guys? Anybody know? Glucagon will actually put the glucose back into the liver, and it stimulates the pancreas to do its thing. So when we have a calcium channel blocker or beta blocker, very similar physiology here, that's why we give the glucagon. This is a hormone that the liver makes, and by giving it, we can reverse some of the side effects of the overdose here. Okay. Does this patient need a vasopressor? Oh, probably so. Dopamine is not the drug of choice in pediatric patients because of the harm it can do with the alpha effects and vasoconstriction. Not a good thing. Norepinephrine is often a last resort, although in the recent literature, since doing these slides, it has become a little bit more acceptable in children. We use epinephrine quite a bit in kids. Norepinephrine, as you guys know, increases heart rate. In this particular case, that's a good thing because the heart rate's so slow. We want that side effect. So this is what we found. The patient was given CPR and fluid challenge and epi in the field. On arrival, heart rate was 100. That's an improvement. Pulse was present. We gave, I don't know why we gave 200 milligrams. If I think back in that case, it might have been two separate boluses, maybe. Sorry, I don't have the details on why. Another fluid bolus, epi was started. We estimated the dose of rapamyl at 4.8 grams. You can imagine how this little one's handling that. The child was flown to UVM in Burlington, where they had a children's unit ICU stay. Unfortunately, the child had complications with aspiration and pneumonia. and liver failure, long hospital stay, but guess what? The child recovered, went home neurologically intact. Absolutely amazing. And that's the end of the story. So I thought those were two really good cases of children in trouble. They actually kind of derived from EMS. They don't tell OEMS that they're not from our region, but they really fit the bill because there are so many gems to learn in those cases. You know, the child who may be going into shock to be ready and to treat that shock appropriately, to think outside the box. In a tox case with children, they can be very, very serious and can kill them. And certainly this child went beyond one pill. 1 or 2 pills of verapamil could put this child down in the grave. So it's a wonder that this child even survived. You know, grandma was good in the fact that she checked the child a half an hour after nap time. So I'm guessing that the child had just ingested these within a very short period of time.
So liver wise, do you think this gonna never be will there be complications for the rest of the child's life?
Down the road, probably not. In liver shock like that, and liver failure, if it's an acute problem due to a medication or an insult from surgery, often those recover pretty quick, 6 weeks, 3 months roughly. But if the patient has had a viral illness, sometimes they can go on to trouble with chronic liver failure. Mono is famous for that, which is the Epstein-Barr virus. Hepatitis can do that, put the patient into chronic liver trouble. So it's not very usual with medications on an acute tox thing. Now, if it's a medicine they've been on for a while, let's say they've been taking, they've been taking 2 extra strength Tylenol every 6 hours for chronic pain for 3 months. Then they can go into chronic liver failure because of the acetaminophen. Because Tylenol is metabolized in the liver. The enzyme that breaks it down gets exhausted. The liver can't make any more. There's no more functionality to manufacture that enzyme to break it down. As a result, the Tylenol builds up its metabolite, which is toxic to the liver, and hence, boom, it's gone. Yeah, there's a reason for everything. Pretty cool. Any other questions? You guys have been so patient. I really, really appreciate your patience. What time are we at? Yeah, okay. That's great. My apologies to all of you being so patient. I really appreciate it. Any questions at all? Okay, yay. Thanks, you guys. Our next M&M is in May, I believe. The Monday before Memorial Day. Before you all go, let me give you the date. Yeah, May 19th, same bat time, same bat channel. So, thanks everyone. Tom, did you have any housekeeping things to wrap up?
Nope, I got everybody's name and number, so I've already done the online rosters. When are you in your office again, sir?
I'll be there Monday.
Okay, I'll bring the rosters by or leave them in your mailbox so you can sign them.
Absolutely, yeah. Be glad to do that. So.
All right, cool. I might pop in anyway to talk to you about that other thing.
Oh yeah, I looked at case. Oh yeah, I need some detail from you. I appreciate it.
All right, I'll talk to you on Monday.
Thanks everybody. You're great. Appreciate all you do.
Thank you, thank you. Again, I apologize, everybody. We'll see you next time. Thank you.
Print the sign.
I'm glad we didn't cancel.
Oh, do that.
I'm glad we didn't cancel. We muddled through.
Sure did.
Thanks for the use.
You're all set, Doc, you said?
Yeah.